Hello, everybody. I am Dr. Ganesh. I'm currently working in UPUMS Saifai as an associate professor. The topic for today's presentation is maintenance and removal of chemopods, TIVADs. I was told that the session was after tea break, and I thought it would be a good idea because inserting a chemopod is fun, but maintaining it is kind of a lifelong procedure, and we attribute it to be done by sisters. But it is equally important because if it's not maintained well, it's not going to survive. It's not going to serve the patient. So the functional status of TIVAD depends on the structural design of the chemopod that you're using, the implantation technique, and the maintenance. The overall complication rate is as high as 12.5%. There are some papers which say it's as high as 25%. And proper catheter maintenance is necessary to avoid these complications. What was initially thought was because both are central venous access devices, TIVAD and central line should have similar monitoring maintenance protocols. But it doesn't work so because the biophysics behind the two devices are different. A central line just has a laminar flow, whereas because TIVAD is a closed system, it has a vortex flow here and it has a laminar flow in the catheter part. So because of this additional component, the maintenance is going to be very different and it has to be respected. Coming to how you begin approaching the chemopod, first and most important thing is site preparation. First thing you do is you look for redness, tenderness, warmth, swelling in the area of where the chemopod is present. You have to maintain hand hygiene before and after palpating the catheter site, before and after inserting or replacing, accessing, repairing, or dressing any intravascular catheter. So this is very important, which is often forgotten in a busy chemo suit. It's very important to wear sterile gloves. They even recommend gowns and masks. Position of the patient is important from site preparation point of view because the head of the patient should be turned to the opposite side to avoid contamination from if the patient coughs or sneezes or something. It is ideal to use a 2% chlorhexidine based solution. The way we drape a part, painting and draping is done. This painting, it's mentioned that it should be done at least twice and it should be left for at least 30 seconds. So this is what is recommended in most of the nursing guidelines that I could see. It should not be wiped away. It should be allowed to air dry. And the maximum treatment area is around 5 into 5 centimeters. So it's approximately 130 centimeters square. An aseptic non-touch technique is also mentioned. Here they have introduced the concept of key part and key site, and these two sites should be protected. Key site is any portal of entry into the patient. So the port at which the septum at which you enter the needle is the key site. And key part is basically the syringe strip, the drip set, and the needle, syringes, etc., which will enter the septum. There are three fields that have been mentioned. General aseptic field, which is the decontaminated and disinfected procedure tray. Critical aseptic field is a sterile drape or barrier used to ensure that there is asepsis, and a microcritical aseptic field where a small protective sterile surface that such as a cover of a syringe or needle or something. Coming to how do you access a chemoport, you can use local anesthesia because it is going to be painful for the patient. Some people use topical patches. You have to prime the needle with whichever, preferably NS, before you insert it. You have to palpate the base, usually a 3-finger. I'm sorry, I think can you see my slide? No.
No. I can't see it.
I think Meghna started sharing it. Yeah, is it visible now?
Yes, no.
Thank you. So you palpate the base of the chemoport using a 3-finger technique and you stabilize it. And then you insert the Huber needle vertically so that it enters the septum. And using a 10 ml or bigger syringe. So never use a smaller syringe. Smaller syringe doesn't mean that the pressure is low. It is going to cause a higher pressure. So always use a 10 ml or a bigger syringe to aspirate. If you see the blood being aspirated, it's called as flashback. And then you gently flush with NS. Then you stabilize the needle and you appropriately dress the needle. What is special about this needle? This is called as a Huber needle, which is used to assess a port. It is a non-coring needle. And what does non-coring mean? It's specially designed to prevent the damage to the septum. So it is flattened or offset bevel. So what it means is the hole is not at the tip of the needle. It is at the side of the needle. So if you use a regular needle, some part of the silicon of the septum can get damaged. And these small micro silicon particles can even enter into the catheter and cause blockage of the catheter. So that's why you use a non-coring needle, and this will slice rather than puncturing the septum. There are various lengths and diameters of non-coring needles available. It can be from 19 to 22 gauge, and it can be 15 to 25 millimeters in length. It can be straight or angled or winged or with Y-side. The basic idea is use the smallest possible, because the smaller you use, the less damage it will cause to the septum, and the longer the life of the port is going to be. Whenever you use a needle, let's say if the patient is on continuous infusion, or if the patient is admitted and needs care for, let's say, total parenteral nutrition or blood transfusions, the needle has to be replaced every 7 days at least, or if there is earlier, if there's any other indication. There are some studies which have said that it can be kept for several weeks, but I think it's better to remove it at least once in 7 days. And if you're using it for blood products, it is advised that it should be replaced within 24 hours. So these are some of the indications, as in the size of the needle recommendation with the drug that you're going to infuse. Also, chemoports for breast cancer is usually put in the chest, but then they can be femoral ones, there can be peritoneal chemoports as well. So the longer length needles you'll need for various special conditions. And what is important is the orientation at which you you insert the needle. So when the non-coring needle is inserted into the injection chamber at the middle part of the silicon diaphragm with a 180-degree orientation, that is when you'll get the best irrigation. So I'll tell you what 180-degree orientation is. And the vortex flow within the injection chamber depends on the orientation of the non-coring needle. So that is why this is important. So it is not that if it's what we use is butterfly. So butterfly can rotate in any direction once you insert it. So it's necessary to make sure that it is inserted in the right direction and it's held securely in that particular direction. Also, it is inserted till you hit the base of the chemo port. But if you put a lot of pressure, there can be leakage, there can be pain during removal, because the tip of the needle is going to get bent. So when you are removing this out of the skin, it's going to cause a lot of pain to the patient. So you have to be gentle here. And also what is important is you should vary the puncture site. So what many sisters do is, because there's a small scar of the previous needle inserted, they try to use the same scar site, try to enter the chemo port. First of all, the success rate of that is going to be different, because it's important to stabilize the chemo port. And sometimes it can even damage it. And let's say you're lucky and you keep entering the same hole in the septum, that is also going to cause a lot of damage to the septum. So when a company states that the port can accommodate 2000 punctures, it means that equal access to the entire port. So not in and out of the same hole. So basically, it's important that you vary the sites of the puncture as well. And like I said, syringes should be sterile and at least 10 ml. The smaller syringes increase the pressure in the catheter wall and it can cause risk of rupture. If you want to use a smaller syringe, they'll have a different hub. The hub is of the diameter of a 10 ml syringe. Only those smaller syringes you can use. Otherwise, use at least 10 ml of bigger syringes. What is other thing that is important is you have to observe septic shower. So this can occur even if on inspection, the site is free from infection. But as soon as you give let's say you flush the chemo port and the patient is suddenly going to have shivering or rigors, fever, this is because of flushing of bacteria that is collected in the TIVAD catheter. So it's important that if this is happening continuously, you'll have to probably start antibiotics or decide about removal of the chemo port. And some special access scenarios such as sampling. Blood sample can be withdrawn from a chemo port. There are two methods that have been described. One is a draw and discard method. What you do is you draw up to 3 to 5 ml of blood using a syringe. You discard it because it is going to have the fluid in the catheter. and then you take a newer syringe and you withdraw the required amount of blood for laboratory tests, and then you again have to rinse it. Depending what they say is coagulation profiles need a lot of blood to be withdrawn and discarded because it's going to be contaminated in that area, because especially if you are locking the catheter with heparin. So another method which has been described, which I had not heard about before, was push and pull method, or a mixing method. So what you do is you take a 10 ml syringe, you withdraw 4 to 6 ml of blood, and then you flush it back. You do it 4 times. And what they're saying is it's going to be the blood of a peripheral vein sample, basically. So here what you're doing is you're reducing the amount of wasted blood as well. And it's also reducing the hub manipulation because you've just inserted the syringe once. You don't have to change the syringe. So this is one of the methods that you can use. When you're using blood culture, sample for blood culture can be taken using this, but then you do not perform the initial flush to determine patency after accessing the chemo port, and you do not discard the initial sample because that is what has to be sent for blood culture. Coming to high pressure injections, Dilip sir mentioned about using chemo ports for CT scans. So in such situations, you need to make sure that you have a high pressure access port, and you also have to use a high pressure needle. So if you have a high pressure access port, it's very important that you identify the port and the needle. So you have to see the patient records, you have to see the patient identity card or bracelet. You have to palpate the port because you can make out from the triangular shape and those 3 dotted structures that what kind of port it is. So power port is going to have a triangular shape. And also you can take an X-ray to identify if it is a power port or not. So only use CT scan injections when you are sure that the patient has a power port in situ. And smaller needles can cause leakage. The needle should also be securely taped to the catheter again. The catheter length more than 20 centimeter will reduce flow rates. Do not exceed the recommended pressure. And there is some debate that the Grosong valve, which is present on a catheter, can reduce the flow rate compared to open valved ones. And another important thing is the contrast media should be warmed to 37 degrees Celsius, because if it's not warmed, the viscosity is going to be higher and the flow rate is going to be as much as 50 times lower. And again, you have to rinse with every use. The recommended pressure for continuous infusions, such as if you're using an infusion pump, is 25 psi. And for par injection, the maximum pressure is 300 psi. And these are the recommended needles depending on the flow rates that you need. Also, some people say because it can be positional, the chemo port, if possible, the patient's arms should be vertically above the shoulder with the palms of hands on the face of the gantry when you're doing a infusion of the CT contrast. Now coming to the flushing and locking procedure. Flushing is basically to maintain the catheter patency. Catheter locking is called when you fill a catheter lumen with a solution and allow it to dwell while the catheter is idle. This makes sure that the blood doesn't trickle back into the catheter lumen so that it can avoid thrombosis. At least use 10 ml. And how do you flush a catheter? Orient the bubble of the non-coring needle in the opposite direction, like I had mentioned before. Use pulsatile flushing technique. So instead of injecting 10 ml in one go, keep injecting short boluses of 1 ml solution interrupted by brief pauses. So it says that this will cause a lot of small thrombi to be dislodged. And then also estimated 40% of the initial catheter locking solution was lost due to leakage during installation. So it's also very important that you do it slowly. Another thing that you do is when you are removing the needle after flushing, make sure that it is under positive pressure. What positive pressure means is during the needle withdrawal, you clamp the infusion set when a part of the solution is still left behind. So let's say 0.5 ml to 1 ml. And this makes sure that the needle is disconnected in a positive pressure kind of a situation. The frequency of the situation flushing is variable. Every time you remove a needle, every time a new IV line is connected, there should be flushing. Again, this is not followed by most of the sisters. And maintenance flushes, some people say it should be done every 4 weeks. Some recommended it every 6 weeks. And there are some papers which say that up to 3 months is also enough when the patient is not actively using a chemo port. Coming to the type of solution to be used, this is debatable because some people use just normal saline and some people use heparin. Heparin has its side effects because some people say it can increase the risk of biofilm formation, and it also predisposes to heparin-induced thrombocytopenia. And this whole debate of heparin versus no heparin came because of valves, and the Grosson catheter is the most probably common chemoport that you'll use, which will have a Grosson catheter. So Bard says that if you're using Grosson catheters, you do not have to use heparin, and you can use only normal saline to lock the or flush the lumen. But for open-ended ports, heparinized saline is recommended in most of the package inserts. But there have been some randomized controlled trials in Italy and in Leuven, which say that there is no difference between using normal saline and heparin with respect to the complications rate. In fact, in the Italy study of 2001, they found that Grosson catheters have higher complication rates because their chances of blockage because of the valve is higher and the flow rate is also lower. But basically, it's non-inferior. Using NS is non-inferior to using heparinized solution. Some people also recommend antimicrobial solution for flushing and especially for locking, especially if the patient already has catheter-induced blood infection. The solution to use and the method of injection and how long to use the antimicrobial solution is all still debatable. There are no guidelines as such on what to do. Coming to blocked catheters, it is possible that you can come across a blocked catheter, especially because of these small blood clots or fibrin sheaths or particulate matter which are obstructing the lumen. And in such situations, you can use a fibrinolytic solution instead of redoing the whole procedure. There are various methods to instill these solutions. What is recommended is a three-way stopcock method or a dual syringe method. This is done very gently. You have to make sure that you repeatedly flush as well as aspirate to make sure the clot doesn't enter into the blood system and comes out of the syringe. And this can take up to half an hour. You need to give some time also for the fibrinolytic agent to act on the fibrin. So this is going to take a lot of patience, but you can save a blocked catheter if you do this with patients. Various drugs have been recommended. Alteplase can be used, retiplase can be used, recombinant urokinase can be used as a fibrinolytic agent. Arterial catheters do not need, they are not going to get blocked. So you don't have to necessarily check for blood flashback. And you have to rinse with NS and heparinized solution. There's no doubt about it here. For epidural intrathecal catheters, you don't use heparin. For peritoneal catheters, you use a larger volume of syringe. Deaccessing, that is removing the needle from the hub. This is also very important. It has to also be sterile. Make sure that the sister remembers to flush before deaccessing. And and make sure that the reservoir is stable and you pull the needle gently and continuously. And at any point of time, make sure that you never leave open the needle to air, irrespective of it being open or Grosson, because it can cause air embolism. Coming to the removal of a chemoport, the indication is when it's no longer needed or if a complication develops. There are studies where more than it has been kept in situ for as long as 5 years without any complications. So I don't think there's a set deadline for any chemoport for it to be removed. Infection is the most common reason why you remove it, but removal is only recommended if it is persistent and if it relapses despite antibiotics. The procedure for removal is also similar. You have to make sure that there is strict asepsis. You can do it under local anesthesia. You have to incise the fibrous tissue. Don't excise it because it's going to cause a lot of bleeding. Cut the anchoring sutures. There are two methods of doing it. Some people pull the catheter first and then remove the port. Some people remove the port first and then remove the catheter. So it depends on what you want to use, which method you want to use. Some people suture the tunnel from which the catheter is going passing so that you make sure that the blood doesn't collect in the pocket. And you have to make sure that you check for the tip to make sure it's intact. Apart from this, it's very important to educate the patient with respect to maintaining chemoport. the patient should maintain basic hygiene, and also it's important to note that the patient can go back to all normal activities once the port site is healed. And there is a Twiddler syndrome, which is mentioned because if the patient keeps scratching the port side, it's possible that the sutures will give away and it can cause inversion of the port. So patient education is how you avoid it. There's a nursing protocol which was developed in Leuven Management Protocol, which recommended that a dedicated vascular access specialist team should be present for every hospital, which has physicians, technicians, nurses, physician assistants, who have an idea to troubleshoot if you have any issue with respect to chemoports. This is probably going to be very important in the future when a lot of chemoports, when it becomes basically a routine procedure. To conclude, I would like to say that maintenance is necessary, patient education is necessary, and healthcare staff also needs treatment. And it is our responsibility as well to make sure that our sisters are well trained in maintaining a chemoport. Thank you.